This is an 8-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. This talk is about upper GI cancer. It's the second part of 4 on this topic. It covers investigation, staging, treatment, palliation, and survival. The speaker is Francis Hughes, upper GI surgeon and lead clinician for upper GI cancer MDT at Barts Health NHS Trust.
So once the patient has been diagnosed with their esophageal cancer, they will undergo staging investigations. Accurate staging is obviously essential. We often now spend several weeks with staging investigations. This is difficult for patients, but it's important that we impress upon them that getting all the correct information at the beginning to make the right decisions is so important. Everybody will have a CT scan of the chest, abdomen and pelvis looking for metastases, particularly in the lung and liver. Provided we don't identify any metastases there, then they will go on to an endoscopic ultrasound and PET scan, provided they would be fit for radical treatment. If there is extension of the tumour across the gastroesophageal junction, then we would do a laparoscopy to look for peritoneal disease. You can see peritoneal disease there over the surface of the stomach. The PET scan is positron emission tomography. It depends on the difference in the metabolic activity of the cancer to normal tissue. And if you look at this picture here, this is the liver on a CT scan, which shows no evidence of any lesion, whereas on the PET scan you can see there's a hot spot there. So PET scanning has been shown to upstage esophageal cancer in up to 30% of cases. So we now do a PET scan before we embark on radical treatment. So this is the pathway. We start with the CT scan. If they have metastases, then they go into the palliative pathway. If there's no metastases, then and they're fit for surgery, they go on to have the endoscopic ultrasound, laparoscopy and PET scan. And if we identify a very early cancer, so T1 confined to the mucosa, then those patients will go to surgery. In most instances, there are very rare indications for an endoscopic resection of a small cancer that's well differentiated, non-ulcerated and confined to the esophageal mucosa. Every other patient which has a T2 or node positive will have a course of neoadjuvant chemotherapy, and following the chemotherapy they go on to a repeat CT scan. Provided there's no sign of progression of the disease, then they would undergo surgery. So 50% of cases at the time of their staging CT scan have metastatic disease, and that's at initial presentation. When we then go on to stage them further with the endoscopic ultrasounds, laparoscopy and PET scan, and exclude the people who are unfit for radical treatment, then that's how we end up with the 20% who are suitable for curative treatment. As with all cancers, it's a multidisciplinary approach, and a multimodality treatment, certainly for esophageal cancers, chemotherapy, radiotherapy and surgery are all used. The treatment of esophageal cancer, 70 to 80% of cases will be palliative treatment only. Adenocarcinoma, the only potential for cure will be resection, and that will more often than not be 99% of the time will be esophagectomy. For squamous cell carcinomas, the squames, much the same as the lung, are very radiosensitive, and radical combined chemotherapy and radiotherapy is usually the first line treatment, apart from very early squamous cell cancers, which we would resect. It is slightly controversial whether squamous cell cancer should be treated by surgery or chemoradiation. Chemoradiation has a fairly high morbidity, but nowhere near as high as esophagectomy. So if they have chemoradiation and they have a recurrence after that, then they may be able to have salvage surgery, which may still be with curative intent. Patients have to have some form of fitness assessment, even if they're just going to be having palliative radiotherapy. The more radical the treatment, the more rigorous the fitness assessment, and this also seems to be taking time for patients who are going through their pathway. So the palliative treatment, approximately 20% of patients will just have palliative supportive care and referral for Macmillan support. Endoscopic palliation for around about 30%. Approximately 40% of patients now are having palliative chemotherapy, and this is a change compared to several years ago when stents were the main palliation for esophageal cancers, but we use much more palliative chemotherapy now. Palliative radiotherapy mainly for squamous cell carcinomas, but occasionally we use it for adenocarcinomas if there is no other alternative. Palliative surgery, to my mind, is a tragedy. Patients should not be undergoing the type of major surgery for an esophagectomy if we are not fairly convinced, or very convinced, that we will achieve a cure. The detrimental effects on the quality of life last up to 2 years, and so unless the patient is expected to survive that long, then I feel we shouldn't be putting them through the surgical pathway. So this is just to look back over the years to see what's happened to perioperative mortality. My predecessor at the London Hospital, who retired several years ago now, back in the 1980s, wrote a paper, and the mortality of esophagectomy at that time was 20%. Fortunately, it has come right down now, and this figure is from the Association of Upper GI Surgeons National Audit, published in 2009, which shows that the complication rates come down to approximately 4%.
That concludes this webcast on upper GI cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.